Have you ever wondered what your heart is really doing all day, every day? I mean, not just when you're sitting still, but when you're stressed, when you're exercising, maybe even when you're asleep.
Yeah, because that standard ECG, it's just a snapshot, isn't it?
Exactly. And sometimes the real story, the important stuff about your heart's electrical activity, it's happening when the camera's off, so to
It's,
speak.
it's those hidden moments, definitely, those
Yeah.
infrequent symptoms or the rhythms that only pop up under certain conditions.
Yeah.
That's often where the key is, the key to really understanding someone's heart health.
And capturing those moments needs a very specific tool,
It does.
which is exactly what we're diving into today. Welcome back to the deep dive. We're getting into the pretty fascinating world of ambulatory cardiac monitoring. We'll be focusing mainly on the Holter monitor, but also related tech.
It guides us through, everything, the history, the basics, how it works technically, what kinds of things it finds, and crucially, the role of the technologist, the person who really makes it all happen.
So our mission today, think of it like this. We're unlocking the insights inside this guide, page by page, giving you the shortcut to being really well informed on what this ambulatory monitoring is all about.
Sounds like a plan.
And actually, before we jump in fully, we should give a special thank you to London Heartbeats Z Academy in the UK. Their educational support really helps make these deep dives possible.
That's great.
Yeah, and for those of you listening who want to go even deeper on topics like this, honestly, check out their website. They've got over 150 courses. Plus, you can subscribe to them on Facebook, Instagram, YouTube, get free, regular updates. Definitely worth exploring if you want to keep learning.
That's a good shout. Continuous learning is vital in this field.
Uh-huh.
And this document, it really works as a foundational text. If you look at page 5, the learning objectives,
Right, I see that.
they basically lay out our roadmap, don't they? Defining ambulatory ECG, why it's used, especially for arrhythmias, the procedure, step by step, spotting artifact, disconnection, why it's good for sudden cardiac death risk assessment.
Wow, it covers a lot. Normal events, recording systems, calibration, lead selection, the diary.
Analysis modes, report content, false positives, equipment care.
Mm-hmm.
Yeah, it's all in there. It's our guide for this whole discussion.
Okay, let's unpack this then. Starting maybe on page 6, the intro and history. What is a Holter monitor at its core? How's it different from that quick ECG in the clinic?
The big difference, fundamentally, is time. A standard ECG. You get maybe, 10, 15 seconds of heart activity?
Yeah, barely anything.
A Holter gives you a continuous recording, typically 24 or maybe 48 hours.
Mm.
It means putting electrodes on the chest, connecting them to a small portable recorder the patient just wears.
So it's like you said, not a photo, but a whole movie of the heart for a day or two.
Exactly like that. And then the analysis of that recording, that's where the insights come. It gets processed, interpreted by a doctor, the hookup itself. Pretty quick, maybe 15 minutes. Patient wears it, goes about their day, brings it back. And it's always ordered by a doctor. It's a diagnostic test.
Okay. The document also mentions ambulatory blood pressure monitoring here. Similar idea.
Similar principle, yeah, but different measurement. Instead of electrical activity, it's blood pressure. An ABPM device, it automatically measures and stores your BP and heart rate at set times. Maybe every 30 minutes during the day, every hour at night.
And why do that?
It helps assess how the heart muscle is reacting to daily life, normal activities, stress, sleep, not just a single reading in a clinic, which, let's face it, can be skewed by nerves, the whole white coat thing.
Right, makes sense. But what if symptoms are even rarer? Like they don't happen every day or two?
Good question. That brings us to page 7 and other types of monitors. The document mentions event monitors. These are usually smaller devices worn for longer, maybe weeks, even months, typically about a month.
How do they work?
Usually 2 patches or electrodes on the chest connected to the recorder. But here's the key difference. They only store the rhythm when the patient, or maybe a caregiver, feels something and pushes a button.
Ah, so it's user activated.
Mostly, yeah. And crucially, most of them save the ECG from before the button push too. Maybe several seconds, or even longer. Captures what led up to the symptom. Some older ones might only record after the button push, but the pre-event recording is much more useful. You wear it daily just to increase the odds of catching that infrequent event.
Okay. And then there are implantable loop recorders, ILRs. These sound more involved.
They are, yeah. For really serious symptoms, but ones that happen very rarely. Think unexplained fainting. An ILR can be implanted just under the skin, usually on the chest.
How big are they?
Tiny, really. About the size of an adult's little finger. Needs just a small, maybe a 1-inch incision. The battery can last over a year, sometimes much longer now.
And it's always watching.
Always. Constantly monitoring the rhythm. The patient usually gets an activator, like a little remote, to press when they feel symptoms. The device often also records automatically if it detects heart rates that are too fast or too slow, based on how it's programmed.
How do you get the data out?
It's not usually sent over the phone. You need a special programmer machine at the clinic that communicates with the ILR using radio waves to download the stored recordings. It can hold quite a few events, maybe up to 14 or even more, depending on the model and settings.
It's pretty amazing how the tech has evolved for different needs. Page 8 gives a nod to the namesake, Norman J. Holter.
Right, the historical note. He was a professor involved in geophysics, actually. Started out searching radio telemetry, initially for brainwaves, EEG.
Oh, interesting. Not ECG at first.
No, but he pivoted to ECG recording, collaborating with Joseph Gengarelli.
Yeah.
He got a big award for medical technology contributions in '79. His pioneering work in portable continuous monitoring is why we still call it Holter monitoring today.
Cool history. Okay, so we've got the devices, the reasons for using them, but making it work really depends on the people, right? Especially the cardiology technologist. Pages 9, 10, 11 really detail their role.
Absolutely critical role. It starts right at the beginning with applying the monitor. The technologist has to confirm the patient ID, check the reason for the test, label everything correctly either physically or on a digital card.
And explaining it all to the patient.
Hugely important. Explaining the purpose, what's required,
Yeah.
especially emphasizing that patient diary. They need to know how vital it is to log not just symptoms, but activities, medication times, and the exact time everything happens. That correlation is key.
Skin prep and electrode placement sounds simple, but probably crucial. Page 9 mentions this.
Foundational. You need good signal quality. That means proper skin prep, maybe gentle abrasion, cleaning with alcohol to reduce electrical resistance, then careful electrode placement, securing the wires well, all to minimize artifact, electrical noise or interference. Muscle movement, poor contact.
Yeah.
It can mimic heart rhythm problems and makes the recording really hard, sometimes impossible, to interpret accurately. Bad prep, bad placement equals bad recording. Simple as that.
Okay, so the monitor's on what then? Page 10 covers this.
The tech often runs a quick baseline recording, maybe a rhythm strip, sometimes even a 12 lead if the system allows. This confirms the leads are in the right spot, the signal looks good, especially checking for a nice tall R wave, which the analysis software relies on.
Checking the machine works too.
Yep, ensuring it's recording properly, like if it's an older tape model, that the tape is moving. Then securing the recorder comfortably, maybe helping the patient get dressed over it, and giving clear instructions on wearing it, caring for it, and crucially, when and how to return it.
And the removal process.
When the patient returns, the technologist carefully disconnects everything, cleans the skin, checks for any irritation from the electrodes or tape, and importantly, they talk to the patient again.
Asking about symptoms.
Yes, asking specifically if they had any significant symptoms and carefully reviewing the diary entries with them. This chat gives the tech context and highlights potential areas to focus on during analysis. Then they inspect the equipment, make sure it worked okay, and prepare the recording, whether it's a tape, flashcard, whatever, for the analysis phase.
Which leads us to page 11, the analysis role. This sounds like where the real expertise comes in.
It really is. They start by verifying all the patient info matches the requisition and the recording medium. They review the reason for the test, look at any prior ECGs, and importantly, consider the patient's full clinical picture.
Like what?
Known heart conditions, previous arrhythmias, if they have a pacemaker or ICD, other medical issues like sleep apnea or diabetes, and critically, all the medications the patient is taking.
Why is all that background so important for just looking at an ECG trace?
Because the tracing doesn't exist in a vacuum. A particular finding might be totally expected or less concerning in someone with a known condition or on a certain drug. But that same finding in someone else could be a major red flag. Medications, as we'll discuss later, can have huge effects on the ECG.
Right, so the tech gathers all this context.
Yes, enters it into the computer analysis system. Then they initiate the analysis following the facility's specific protocols.
Does the computer do everything?
It does a lot of the initial scanning and sorting, identifying potential abnormalities. But the technologist's skill is crucial for reviewing, verifying, and interpreting those findings. They identify and save representative strips of arrhythmias, pacemaker function, ST changes, etc. They prepare the formal report using standardized terminology.
So they're creating the summary for the doctor.
Exactly. They take timed examples, note the morphology, the shape of the waves, how often things occur, and compile it all logically. They bear a lot of responsibility for the accuracy of that analysis and the report.
And telling real problems from just noise.
That's a core skill, differentiating true arrhythmia from artifact. They also add comments, maybe about recording quality or other pertinent observations. And, crucially, if they spot something really dangerous during analysis, like sustained V-touch or long pauses, they have to act fast, immediately. Notify the physician or cardiologist. They also troubleshoot equipment issues, software glitches, and sometimes participate in research studies. They're really the bridge between the raw data and the doctor's ability to make a diagnosis.
It's a really complex role. Okay, let's shift to the why. Page 12 starts on indications. What are doctors actually looking for with these monitors?
Primarily, they're hunting for problems that aren't there all the time. Intermittent things. This includes conduction disturbances, problems with the heart's wiring, and arrhythmias, which are abnormal heart rhythms.
Page 12 mentions atrial ectopi.
Right. That's an early beat coming from the atria, the upper chambers, often described as a premature atrial contraction, or PC. Usually harmless, might happen in patterns. Patients often don't even feel them. On the ECG, you see a beat come early, and the P wave might look a bit different or be hidden in the previous T wave.
And ventricular ectopi, PVCs.
Premature ventricular contractions, or PVCs. These are early beats from the ventricles, the lower chambers. Very common. These are often the ones people feel as palpitations, that skipped beat, or fluttery feeling.
Are they dangerous?
The document notes they're common, and not always a sign of disease, especially if the heart is otherwise healthy. But frequent PVCs, or certain patterns, can be concerning, especially in patients with underlying heart problems, as they can sometimes trigger more serious arrhythmias or indicate increased risk. On the ECG, they look different, typically wide, bizarre shape, coming early.
Can they come in groups?
Yes. A single one is a PVC, 2 in a row are a couplet, 3 in a row a triplet. 4 or more in a row is actually considered a run of ventricular tachycardia, or V-touch.
What else are they looking for? Page 13 lists more.
A whole range. Things like atrial fibrillation, AFib, and atrial flutter, abnormal rhythms in the upper chambers. Various types of heart block problems with conduction between the chambers. Bundle branch blocks, issues further down the conduction system. Episodes of tachycardia too fast or bradycardia too slow. Significant pauses or even cardiac arrest. And conditions like prolonged QT syndrome, which is an electrical recovery issue that can increase risk.
Page 13 also gets into cardiomyopathy. What's the link there?
Cardiomyopathy is disease of the heart muscle itself. Monitoring can reveal associated problems. The document describes 3 types. First, dilated cardiomyopathy. The heart chambers, especially the ventricles, enlarge, and the pumping function weakens.
What would you see on the Holter?
Signs of chamber enlargement, potentially arrhythmias like AFib or V-touch, conduction problems like left to right bundle branch block are common, and specific changes in the ST segments and T waves.
Okay, and the second type?
Hypertrophic cardiomyopathy. Here, the heart muscle becomes abnormally thick, especially the left ventricle. This can interfere with filling and sometimes outflow. ECG findings often include signs of that thickening, LVH, sometimes unusual Q waves, and frequently both atrial and ventricular arrhythmias.
And the third on page 14.
Restrictive cardiomyopathy. The heart muscle becomes stiff, not necessarily thick, which impairs the heart's ability to relax and fill properly between beats. Pumping function might be okay initially. Symptoms can mimic another condition called constrictive pericarditis.
Page 14 also mentions sudden cardiac death. How does monitoring relate?
This is a really critical indication. Sudden cardiac death, or SCD, usually refers to unexpected death from a cardiac cause, most often a life-threatening arrhythmia like ventricular fibrillation, sometimes related to conditions like prolonged QT.
Can Holter predict it?
It's often unpredictable, the document notes. But monitoring can sometimes pick up underlying rhythm disturbances, like frequent complex PVCs, non-sustained V-tach, or significant QT prolongation that indicate a higher risk. It's important to clarify, sudden cardiac death often means cardiac arrest del chaving, the heart stopping, which is potentially reversible if treated immediately. Monitoring helps identify those at risk.
Got it. So what symptoms would make a doctor think, okay, let's get this person a Holter?
The classic one is palpitations feeling the heart race, flutter, pound, or skip beats. Also, dizziness or lightheadedness, nausea, chest pain or discomfort, angina, shortness of breath. Pain radiating to the back, jaw, or arm can also be cardiac. And importantly, syncope, actually fainting or pre-syncope, that feeling like you're about to faint. Unexplained fatigue can sometimes be a clue too, even some central nervous system symptoms. Monitoring tries to link these feelings to what the heart is actually doing electrically.
Okay, so diagnosing arrhythmias, blocks, evaluating symptoms, what else? Page 15 lists more indications.
Evaluating therapeutic interventions, that's a big one.
Like seeing if meds are working.
Exactly, especially antiarrhythmic drugs. You do a Holter to see if the medication is actually suppressing the abnormal rhythm you're trying to treat.
Makes sense. What else?
Evaluating pacemaker or ICD function. Checking if the device is sensing the heart's own rhythm correctly, if it's pacing when it should capture, if the output is right. Also detecting myocardial ischemia, reduced blood flow to the heart muscle.
You can see that on a Holter.
Sometimes, yes. You might see changes in the ST segment during periods of activity or even rest, which could indicate ischemia. This is relevant for evaluating anti-ischemic therapy, managing known ischemic heart disease, post-heart attack monitoring, or in patients with valvular heart disease.
Any other reasons?
Research has listed things like evaluating patients in cardiac rehab, studying heart failure medication trials, planned electrophysiology, EP studies, and a few others. Monitoring patients with peripheral vascular disease, sleep apnea, COPD, electrolyte problems, or for risk stratification in certain populations.
It's a really versatile tool. This brings us back again to page 16 and the patient diary. It seems like we can't emphasize this enough.
Absolutely critical. The document hammers this home. The patient must carefully record symptoms, activities, and events during the monitoring period. And meticulous timing is crucial for making the diagnosis.
Why is the timing so vital?
Because the person reading the scan, the physician interpreting it, needs to look at the ECG strip at the exact time the patient reported feeling something. Let's say the patient logs felt dizzy at 2:15 p.m. The interpreter looks at the 2:15 p.m. tracing. Is it normal sinus rhythm? Or is there a long pause or a burst of rapid AFib? That correlation is everything.
So what kind of things should they be logging?
Definitely any symptoms. Palpitations, shortness of breath, fatigue, dizziness, chest pain or discomfort, arm-jaw pain, nausea, fainting or near fainting. Even if the pain isn't typical chest pain, maybe neck or jaw soreness, heaviness, pressure, sharp pain, indigestion, log it with the time.
And activities.
Yes, things that might trigger rhythm changes. Meals, stimulants like coffee, chocolate, smoking, taking medications, log the time, periods of stress, anger, frustration, sorrow, anxiety exercise, sexual activity, even things like bowel movements, straining, heavy lifting, or hyperventilating.
It helps rule things out, too.
Exactly. It helps exclude false positives or false negatives. If a patient has lots of PVCs but felt absolutely nothing, that's important. If they felt terrible palpitations but the ECG was normal, that's also important. The diary provides the essential context for interpreting the electrical data.
Okay, shifting gears to the technical side again, page 17 discusses lead placement. It's not always the full 12 leads we see on a standard ECG, right?
Correct. For ambulatory monitoring, you typically use fewer leads, usually 2 or 3 channels, sometimes more depending on the system. The goal is to choose lead configurations that give the clearest view of the P waves, QRS complexes, and T waves over the entire recording period, so you can reliably identify rhythm and conduction abnormalities.
Which leads are best?
The document recommends leads 2 and V1 as generally providing the most useful information for rhythm analysis, spotting P-skis, PVCs, AFib, flutter, SVT. You need good key wave visibility to distinguish supraventricular from ventricular issues.
And if you're specifically looking for ischemia, those ST changes.
Then leads V2, V5, and AVF are often recommended. Lead 2 is popular because it usually shows tall, positive P, R, and T waves, making things easy to see. It's good for sinus node and atrial arrhythmias and looks at the inferior wall of the left ventricle.
And V1, why is that one so important?
V1 is really helpful for looking at ventricular arrhythmias, ST segment changes, and importantly, bundle branch blocks. It helps distinguish between PVCs originating in the right versus the left ventricle. And critically, the shape of the QRS complex in V1 is often key to differentiating between a dangerous ventricular tachycardia and a less serious supraventricular rhythm with aberrant conduction, which can look similar but have very different implications. You have to scrutinize V1 in those wide, complex tachycardias.
So the lead choice is strategic, depending on what you need to see best over time. Okay, let's move into the specifics of what might be found. Chapter 5, starting page 18, covers conduction disturbances.
Right. And page 18 just shows that image of the heart's electrical system, SA node, AV node, bundle of HIS, the branches, Purkinje fibers. It's a visual reminder that problems can occur anywhere along this pathway.
Page 19 introduces the topic and talks about sinus block or arrest.
Yeah, this is when the SA node, the heart's natural pacemaker, just fails to fire, or the signal gets blocked coming out of it. It results in a pause, a dropped beat on the ECG where you expect a P wave and QRS but get nothing. The example tracing shows that gap.
Then page 20 gets into AV blocks, problems getting the signal from atria to ventricles.
Exactly. First-degree AV block is the mildest. The signal gets through every time, it's just consistently delayed.
Yeah.
So the PR interval, the time from the P wave starting to the QRS starting, is longer than normal, over 0.2 seconds. But it's the same for every beat. The figure shows that constant long PR.
And second-degree type 1, Wenckebach.
This one has a pattern. The PR interval gets progressively longer with each beat. Longer, until finally a P wave occurs that isn't followed by a QRS. A beat is dropped. Then the cycle usually resets and starts again. The tracing shows that gradual lengthening, then the dropped QRS.
Page 21 covers the other AV blocks, second-degree Mobitz 2.
This is generally considered more serious than Wenckebach. Here, some P waves are conducted with a constant PR interval, while others are suddenly blocked, again resulting in a dropped QRS, but without the progressive lengthening beforehand. So you might have 2 P waves for every QRS or 3 Ps for every 2 QRSs, but when a QRS does occur, the PR interval is fixed. The figure shows P waves that aren't followed by a QRS, but the PR interval is consistent when conduction happens.
And third degree, complete heart block.
This is the most severe. There's a total failure of conduction through the AV node or below. The atria, driven by the SA node or another atrial focus, and the ventricles, driven by a backup pacemaker lower down, beat completely independently. So the P waves march along at their own regular rate, the QRS complexes march along at their own, usually slower, regular rate, but there's no relationship between them. Atria and ventricles are divorced, electrically speaking. The tracing clearly shows this dissociation.
Okay, those are blocks between chambers. What about blocks within the ventricles? Page 22 talks about bundle branch blocks.
Right, RBBB and LBBB. This happens when the electrical signal is delayed or blocked in either the right or left bundle branch, which are the pathways delivering the signal to the right and left ventricles, respectively.
What does that look like?
It causes the affected ventricle to depolarize later than the other one, which makes the overall QRS complex wider than normal, usually 0.12 seconds. You identify which branch is blocked by looking at specific patterns in certain leads, particularly V1 and VLEX. For RBBB, you typically see an RSR pattern, like rabbit ears, in V1, and a wide S wave in V6. For LBBB, you often see a deep S wave in V1 and a broad notched R wave in V6. The examples compare these patterns.
And page 23 covers Wolff-Parkinson-White WPW.
Yes, WPW isn't exactly a block, but a conduction abnormality. It involves an accessory pathway, an extra electrical shortcut between the atria and ventricles that bypasses the normal delay in the AV node.
What does that do to the ECG?
It causes the ventricles to start activating earlier than usual, directly via this pathway through normal muscle. This shows up as a short PR interval and a characteristic slurring at the beginning of the QRS complex called a delta wave. The QRS might also be a bit wide, and there can be secondary STT wave changes. The tracing shows the delta wave clearly. The concern with WPW is that this accessory pathway can sometimes facilitate very rapid heart rhythms.
Okay, so those are conduction issues. Chapter 6, starting page 24, shifts to arrhythmias, the abnormal rhythms themselves.
Right, the various types of irregular or abnormal heartbeats that Holter monitoring is so good at finding. The page starts by reminding us of the cardiology technologist's vital role again. Skin prep, lead placement, communication, patient diary, maintenance, and alerting physicians to dangerous findings.
And it sets the benchmark, normal sinus rhythm.
Exactly. Rate between 60 and 100 beats per minute, regular rhythm originating from the sinus node. Of course, normal varies with age, fitness, etc., but it's the baseline text compare against.
Then sinus tachycardia and bradycardia.
Simple enough. Sinus tachycardia is just sinus rhythm faster than 100 BPM, often a normal response to exercise, stress, fever, etc. Sinus bradycardia is sinus rhythm slower than 60 BPM. It can be normal in athletes, but considered potentially abnormal if it's very slow, like under 50 BPM, or causing symptoms, especially if the patient isn't on drugs known to slow the heart, like beta blockers or calcium channel blockers.
Page 25 covers more rhythms, sinus arrhythmia.
This is usually a normal finding, especially in younger people. The rhythm is slightly irregular, speeding up and slowing down, typically in sync with breathing. The P wave and PR interval are consistent. It's just the R to R interval that varies.
Multifocal atrial rhythm.
This is an irregular atrial rhythm where the pacemaker signals are coming from at least 3 different spots, foci, within the atria, not just the SA node. You can tell because the P waves have varying shapes, and the PR and RR intervals are irregular.
Junctional rhythms.
These originate from the AV junction area around the AV node. They typically have rates between 40-60 BPM. The key feature is often what the P wave does. It might be absent, occur just before the QRS with a very short PR interval, or even occur after the QRS, retrograde conduction, often appearing inverted and leads to an AVF. Accelerated junctional rhythm is faster, 6100. Junctional bradycardia is slower.
Idioventricular rhythm.
This originates from the ventricles themselves, usually as a backup rhythm when higher pacemakers have failed. It's characterized by a slow rate, often 1540 BPM, and wide, bizarre-looking QRS complexes. There's usually no relation to any atrial activity. If the rate is faster, between 4100, it's called accelerated idioventricular rhythm, AIVR.
And ventricular tachycardia, VTach.
We mentioned this earlier, a fast rhythm, over 100 BPM, originating in the ventricles. The document notes that 4 or more consecutive ventricular beats, sometimes called a salvo. VTach lasting less than 30 seconds is non-sustained, while longer episodes are sustained. Sustained VTach is a serious, potentially life-threatening arrhythmia that can degenerate into VFib and sudden death.
Page 26 gets into even more serious ventricular issues, ventricular flutter and fibrillation.
Ventricular flutter is very rapid, like 180-250 BPM, and somewhat organized ventricular rhythm, but often so fast that the QRS and T waves merge into a sine wave pattern. There are usually no visible P waves. It's unstable and often quickly deteriorates into VFib.
And VFib.
Ventricular fibrillation is complete chaos. Uncoordinated, quivering electrical activity in the ventricles. There's no organized contraction, no effective pumping of blood. It's a cardiac arrest rhythm, requires immediate defibrillation, and is fatal if not treated instantly.
Okay, switching back above the ventricles, supraventricular tachycardia, SVT.
SVT is a general term for fast rhythms, usually 150 BPM, originating above the ventricles in the atria or AV junction. They typically have a narrow QRS complex because the conduction down through the ventricles is normal, although sometimes they can have a wide QRS if there's also a bundle branch block. P waves are often difficult to see or absent.
And atrial flutter.
This is a specific type of SVT where there's a rapid organized reentrance circuit, usually in the right atrium. It produces characteristic sawtooth flutter waves on the ECG instead of normal P waves. The atrial rate is fast, often 250-350 BPM, but the AV node usually blocks some impulses, so the ventricular rate is slower but often regular, like 2.1 or 4.1 block. It can sometimes degenerate into AFib. The document mentions type 1 typical and type 2 faster flutter.
Page 27 covers atrial fibrillation, AFib, again, and PASIAS PVCs in more detail.
Right. AFib, as we said, is disorganized atrial activity. No distinct P waves, just fibrillatory waves, can be fine or coarse. And the conduction to the ventricles is irregular, leading to an irregular heartbeat. The document notes it's not usually immediately life-threatening itself, but can cause symptoms like palpitations, chest pain, fainting, or heart failure, and significantly increases stroke risk if untreated.
And the premature beats, PACE and PVCs.
PACs, those early atrial beats, are described as the most common cause of palpitations. They occur early, the P wave might look different or be hidden, and the pause after is usually incomplete because the early beat resets the sinus node. Sometimes, if a PAC arrives when the bundle branches are still recovering, it might be conducted aberrantly, resulting in a wide QRS that can look like a PVC. Hence the importance of looking closely at V1. Couplets, 2 in a row, and triplets, 3 as a runner SCT, can occur. PVCs, the early ventricular beats, also cause palpitations. They start in the ventricles, so the QRS is wide, 120 meters, bizarrely shaped, and often points in the opposite direction to the normal QRS. They are followed by a full compensatory pause, usually. Again, they can occur as couplets, triplets, or runs, DTACs. Patterns like bigeminy, every other beat is a PVC, trigeminy, every third beat, and quadrigeminy, every fourth beat, are also common findings.
Wow, so many different rhythms. Page 28 touches on analysis considerations.
Yeah, it reinforces that interpreting these requires understanding the impulse generation and conduction system, the heart structure, the difference in conduction speed between muscle and specialized fibers, and how abnormal pacemaker activity changes the waveforms.
And the general procedure for analysis.
It reiterates classifying each beat, creating templates, having the computer tabulate frequencies, and summarizing the findings in tables or graphs, separating atrial from ventricular ectopi.
Okay, let's move to Chapter 7, page 29, Drugs and Miscellaneous. How is Holter used with medications?
As we touched on, it's crucial for evaluating the effectiveness of antiarrhythmic medications. The goal is usually to see if the drug suppresses the target arrhythmia. The document mentions a common benchmark. Suppression of 85% or more of ectopic beats or runs of VTach might be considered effective.
And it lists the classes of drugs.
Yes, classes 1, 2, 3, and 4 are mentioned here and class V later. It stresses how critical it is for the analyzing technologist to have a complete list of all patient medications, because these drugs directly impact the heart's electrical activity and what's seen on the ECG.
Page 30 shows the classification system, classes 1V, and an action potential graph.
Right, it provides the framework. Class I are sodium channel blockers, Class 2 are beta blockers, Class 3 affect potassium channels, prolonging repolarization, Class 4 are calcium channel blockers, and Class V includes vagatonic drugs like digoxin. The graph visually relates these to the different phases of the cardiac action potential.
Let's quickly run through them. Page 31, class IA.
These primarily block fast sodium channels affecting phase 0 depolarization. Drugs like procainamide, quinidine, disopyramide, they treat both ventricular and supraventricular arrhythmias. ECG effects can include a prolonged QT interval, ST depression, wide QRS, and U waves. Side effects might include low blood pressure or fainting.
Page 32, class EBS.
These also affect sodium channels, but shorten phase 3 repolarization. Examples are lidocaine, mexiletine, toconide, phenytoin, also used for digoxin toxicity. Mainly used for ventricular arrhythmias, they might slightly shorten the QT interval. Side effects can include slurred speech or tremors.
Page 33, class IF.
These strongly block sodium channels, slowing conduction significantly. Flecainide, propafenone, and canide. Used for both SPT and ventricular arrhythmias, but need careful dosing as they can actually cause arrhythmias. Proarrhythmia. ECG changes include prolonged PR, wide QRS, and prolonged QT. Side effects like vision issues or dizziness can occur.
Page 34, class 2, beta blockers.
Yes, these block beta-adrenergic receptors, basically calming the heart down, slowing the rate, reducing oxygen demand. Lots of drugs ending in olol, like propranolol, metoprolol, atenolol, used for tons of things. Ischemia, angina, except Prince metals, high blood pressure, arrhythmias, heart failure, cardiomyopathy, also migraines, anxiety. ECG effects can prolong the PR interval, might shorten QT, U waves may appear.
Page 35, class 3.
These mainly block potassium channels, prolonging repolarization, phase 3, and the refractory period. Examples are amiodarone, sotalol, which also has beta block effects, abutolide, dofetilide, used for various arrhythmias like AFib, VTAC, sometimes bradycardia. ECG changes can include shortened PR, significantly prolonged QT, risk of torsades to points, and prolonged QRS duration, especially with amiodarone.
Page 36, class 4, calcium channel blockers.
These block calcium channels, causing vasodilation, relaxing blood vessels, and slowing conduction through the AV node. Verapamil and diltiazem are key examples used for arrhythmias, controlling rate and AFib flutter, and angina. Others like nifedipine, amlodipine mainly affect blood vessels for hypertension. ECG changes include slowing the sinus rate and prolonging AV nodal conduction, longer PR. Note the sourceless atropine here, which is unusual as atropine increases heart rate via vagolytic action, not a typical CCB effect.
Okay, noted. And page 37, class V.
These are listed as vagatonic antiarrhythmic drugs, primarily digoxin, lanoxin. It slows conduction through the AV node, useful for controlling ventricular rate and AFib, and increases vagal tone. ECG changes are characteristic. ST depression, often with a scooped or hockey stick shape, short QT interval, flattened or inverted T waves, sometimes notched P waves, prolonged PR, and potentially causing AV block or bradycardia at higher levels.
That's a lot of drug effects to consider when analyzing a Holter. Okay, Chapter 8, page 39, brings us to reporting.
Right, the final output. The purpose of the report is to compile everything, the quantitative data, the qualitative findings, and crucially, the correlation between symptoms or events from the diary and the ECG recording.
So it answers the question, are the patient's symptoms related to their heart rhythm?
Exactly. Daily activities, stress, sleep, they can all trigger arrhythmias or ischemia. The report evaluates the frequency and seriousness of any abnormalities found, giving the physician the essential info needed for diagnosis and treatment decisions.
And the technologist's role in the report.
They're the ones processing the raw data, scanning potentially hundreds of thousands of beats, integrating the findings, and summarizing it into a reliable, understandable report. Recognizing important features and correlating them with a diary is key. The document reiterates the common symptoms prompting monitoring: palpitations, dizziness, lightheadedness, pre-syncope, syncope, chest pain.
Page 40 mentions quantitative and qualitative information in the report.
Yes, the quantitative part includes the hard numbers, total beats, counts of different ectopic beats, PVCs, bruns, pauses, heart rate trends, min, max, average, often broken down hourly, and comparing findings during wake versus sleep periods. Frequency of PVCs is usually specified.
And qualitative.
That's the narrative description. The underlying rhythm, significant events like AFib or VTACH episodes, presence of blocks, FT segment changes, and importantly, the interpretation of any correlation with symptoms noted in the diary. The document again references the ACTHA guidelines for standards.
Okay, Chapter 9, page 41 focuses on pediatrics.
Yes, acknowledging that monitoring children requires special considerations. As it simply states, they require a lot of time and patience. Getting good electrode adherence, keeping the device on, and getting useful diary info can all be more challenging.
Pages 42, 43, and 44 provide specific pediatric case examples.
They do, and they're really illustrative. Page 42 shows a 15-year-old boy who fainted playing tennis. His Holter showed atrial fibrillation combined with WPW syndrome via a left lateral accessory pathway. That combination put him at high risk for sudden death, leading to catheter ablation. Page 43 shows Tachy-Brady syndrome in a 9-year-old girl post-heart surgery. Brief runs of atrial flutter followed by severe sinus or junctional bradycardia, a critical pattern to identify. And page 44 is that striking case of the 10-year-old girl initially misdiagnosed with epilepsy after fainting spells triggered by stress or exertion. She was even resuscitated from sudden cardiac death. Her Holter finally revealed the true cause: isolated PVCs degenerating into sustained polymorphic VTACH, specifically bidirectional VT, which coincided exactly with her syncope and convulsive movements. Treadmill testing with Holter confirmed the VT was triggered when her heart rate exceeded 100-120 BPM, a life-saving diagnosis made possible by monitoring.
Those cases really drive home the power of this. Okay, Chapter 10, page 46 talks about pacemaker indications and monitoring. Starts with MBG codes.
Yes, these are the standard codes used to describe pacemaker function. The first letter is the chamber paced, A atrium, V ventricle, dual. The second is the chamber sensed, A, V, D, O, none. And the third is the response to sensing, I inhibited, T triggered, D dual, O none. Sometimes a fourth letter indicates rate modulation, R.
Can you give a couple of examples?
Sure. VDI means it paces the ventricle, senses the ventricle, and inhibits pacing if it senses a native beat. DDD means it can pace and sense both atrium and ventricle and has dual modes of response. AAIR means it paces and senses the atrium, inhibits if it senses a native atrial beat, and has rate modulation based on a sensor, like activity. The list covers the common modes.
And page 47 discusses monitoring pacemaker, EP, electronic pulse generator, and ICD function.
Right. AECG, ambulatory ECG, is essential both before and after implantation. Before, it helps confirm if symptoms like fainting or dizziness are actually due to bradycardia or a heart block that needs pacing, like Stokes-Adams attacks. After implantation, it's crucial for monitoring device function and helping to optimize programming, like the base heart rate.
Does the pacemaker record everything itself?
Modern devices have a lot of internal memory and diagnostics, but the document notes that conventional AECG often offers longer continuous recording periods and can be important for fine-tuning settings, especially with older devices or complex situations. AECG provides the external validation of what the device is doing in the context of the patient's overall rhythm.
How does pacing show up on the AECG?
You see a small, sharp vertical spike, the electronic pulse from the pacemaker, immediately followed by the captured beat. A P wave if pacing the atrium, a wide QRS complex if pacing the ventricle.
Page 48 lists key points for interpreting pacemaker monitoring on AECG.
Yes, things to check. Is there complete capture? Meaning, does every pacer spike result in a corresponding cardiac depolarization? Are P waves visible? If so, are they related to the paced QRS complexes, or is there AV dissociation, which might be normal depending on the pacing mode and underlying rhythm like AV block? Is the underlying atrial rate faster or slower than the pacing rate? These observations help confirm if the pacer is working appropriately for the patient's condition.
Okay. Chapter 11, pages 49 and 50 are review questions. We won't go through them one by one, but they seem to cover all the key topics we've discussed.
Exactly. They serve as a good self-check for understanding the material indications, definitions, symptoms, contraindications, critical values, lead placement, diary importance, reporting standards, pacemaker evaluation, differentiating blocks. A good summary of the core knowledge.
Chapter 12, page 51 is just the summary and references.
Right, pointing to sources like the Journal of the American College of Cardiology and various websites.
Then we get into the Holter report examples, pages 52-75. We can't show the strips, but can you describe the structure and key elements based on the examples? A systole, VTAC, a fib?
Sure. They all follow a similar format. You have patient demographics, the indication for the study, referring physician, medications listed sometimes, then a key summary section.
What's in the summary?
That's the quantitative data dump. Total QRS complex is analyzed, counts of ventricular ectopi, isolated PVCs, couplets, runs, total beats in runs, longest, fastest runs, counts of supraventricular ectopi, PCs, runs of SVT, heart rate data, minimum, average, maximum, longest pause or interval with timestamp. It gives the raw numbers overview.
Followed by the interpretation.
Yes, this is the narrative part. It describes the predominant underlying rhythm, example, sinus rhythm, AFib. It details the significant findings, frequency and type of ectopi, presence of tachycardias or bradycardias, pauses, ST changes. Crucially, it should comment on the correlation between any documented symptoms from the diary and the ECG findings at those times. It might offer a conclusion or recommendation, like in the VTACH example suggesting a medication adjustment.
And the strip directory and ECG examples.
The strip directory lists key moments in the recording, often flagged by the technologist or the system start 10 times. Specific arrhythmias identified, patient diary marker entries, periods of ST change, and the report includes actual ECG strip examples showing the most important findings visually, the asystole pause, the run of VTACH, the AFib rhythm, the PVCs, ST depression, etc. It connects the numbers and narrative to the real tracing.
It really pulls everything together. Page 76 briefly lists some Canadian Holter manufacturers.
Yeah, mentioning Space Labs Healthcare, Philips, GE Healthcare, and Ronan Corporation as key players involved in providing these diagnostic tools and services, highlighting their commitment to cardiology innovation.
Page 77 has that fun picture, puppy Holter monitoring.
Yes. A good reminder that this technology isn't exclusive to humans. Veterinarians use Holters extensively for diagnosing heart conditions in animals, particularly dogs. Same principles apply.
Page 78 shows a diagram of the process.
It's a workflow visual. Shows the patient wearing the monitor, the data coming off various media, flashcard, cassette, disc, into a microcomputer for analysis. The output goes to a laser printer, generating the reports we discussed. Tabular summaries, narrative summaries, graphs, ECG strips, real-time, trend, or full disclosure, statistical summaries. Just maps out the data flow.
And finally, page 80 depicts the evolution of this technology.
It's a great timeline. Starts back in the late 40s, 50s with bulky vacuum tube radio telemetry. Then suitcase-sized recorders with magnetic tape in the 60s. Improvement to smaller tape recorders. A big leap in the 80s and 90s with solid-state recorders using RAM flashcards, leading to the modern era with microchip-based recorders, alongside the development of sophisticated pacemakers and ICDs, also using microchip technology. It shows how far portability and capability have come.
That's a fantastic journey through this whole document. So, boiling it all down, thinking about everything we've unpacked, what would you say are the top 5 takeaways from this deep dive?
Okay, top 5. First, I'd say that ambulatory monitors, like the Holter, give us that crucial continuous data over time, catching heart rhythm events that a simple short ECG in the clinic would almost certainly miss.
Right, number 2.
Second, they're absolutely essential tools, not just for palpitations, but for diagnosing all sorts of arrhythmias, conduction problems, figuring out unexplained symptoms like dizziness or fainting, checking if medications are working, and monitoring implanted devices.
Okay. Third,
the whole process hinges on the skill and diligence of the cardiology technologist. From careful application and patient education about the diary, right through to the detailed, accurate analysis of potentially hundreds of thousands of heartbeats, their role is critical.
makes sense. Fourth point.
Fourth, really understanding the different types of arrhythmias and blocks, AFib, VTAT, heart block, etc., and knowing what they look like on the ECG and what they mean clinically, that's fundamental to interpreting the monitor's findings correctly.
And number 5.
And fifth, just appreciating the evolution.
Yeah.
The technology has become so much more sophisticated, smaller, more capable, allowing its use across the board, adults, kids, even as we saw pets.
That's a great summary. It really captures the essence of this whole field. And, going through all this detail, it leaves me with a kind of provocative thought.
Oh yeah, what's that?
Well, moving from that brief snapshot ECG to this continuous 24/7, sometimes even weeks-long picture, it fundamentally changes how we see heart health, doesn't it? It's not static, it's dynamic, reacting constantly to life.
That's true. It reveals the heart's response in real time to real-world triggers, not just in a controlled clinic setting.
Exactly. So thinking ahead, what future innovations in continuous monitoring could push this even further? Maybe even longer term, more seamless monitoring, maybe built into wearables we use every day. Could that fundamentally shift cardiac care towards being much more preventive, catching things even earlier?
That's a fascinating question. The potential for earlier detection, more personalized risk assessment based on continuous data. It definitely opens up some exciting possibilities for where cardiology might go next.
Something to think about. Well, thanks for joining us on this really thorough deep dive into ambulatory Holter monitoring. We sincerely hope walking through this detailed source material has given all of you listening a much richer understanding of this vital diagnostic technology.
Hope it was useful.
Definitely. Keep that provocative thought about the future of continuous monitoring in mind. And hey, maybe explore some of those resources we mentioned, like from London Heartbeat Zeta Academy. Keep building on what you've learned today.